an SBIRT treatment or an SBIRT standardized process right call, right? But I've added to it a little bit to put that gambling twist to it. Now, as you see, we're focusing on kind of two areas. We're talking about alcohol use disorder and gambling disorder, okay? The alcohol pieces of this training, I kind of kept the same from the original training. I thought it was good, very thorough. So we kept that the same, while with the gambling piece, I added some information from several different great resources, okay? So we're excited to show you and talk to you about this today. You know, for some of you, this is going to be, a review. A lot of you on the call today, I know, work in addictions. So, but for some of you who are either new to this or looking to get in to serve the gambling population, and the portion on SBIRT might be new information for you. Either way, we hope it's helpful information for you, not only serving your problem gambling clients, but clients that are addicted to anything, right? The SBIRT process is a standardized process, systematic process meant to well, there's a few things that it's meant to do, and we're going to get into that. I just remembered I do need to go over these learning objectives. There's 4 of them today. And the first thing we're going to learn is we're going to know the 4 aims of SBIRT. Then we're going to learn 3 benefits using the audit screening tool for gambling clients, because there is a connection with alcohol and gambling that I want to present to you, and why we need to be on the lookout for both. We want to learn the definition of a brief intervention, and we're going to understand the 6 dimensions of ASAM criteria in the referral stage of SBIRT. And as I said, we're going to take a look at those 6 dimensions through the problem gambling lens. So hopefully that might be new. Again, it might be, especially you guys, you folks in our provider network, it might be a review for you. Now, listen, if you have, as you can see, you've got a chat function. So utilize that. If you have questions, I'm going to try to save a couple minutes at the end, and I'll try to get to these. If you have comments, text us, use the Q&A. If I, for some reason, am unable, and a lot of times this happens, if I don't know the information or have the answer, or if I can't get to your question, I'll try to, follow up with you via email. But either way, kicking this off, let me know what you like or dislike about the SBIRT process, okay? Text me. Let me know what you know, and let's get right into it, okay? So when Smithworth, if you don't, those of you who aren't in the provider network and don't know Smithworth, she was the former program administrator for the gambling programs here in North Carolina, for the North Carolina Department of Health and Human Services. She was the predecessor right in between, or right before Amanda. She had asked me to do this in the last quarter of last year when we were putting together all these subject matters. And she thought it would be a great review. And I thought, I think you're right, because we had done this before in summer school there in Wilmington, North Carolina. So I looked at it and I said, man, that's a 3-4 hour training. I got to knock this down. But I'm going to be honest with you. I wasn't updated as I should be, or knew a lot about the real SBIRT process. So I started asking myself questions, dug in a little bit about this systematic, standardized way of screening, providing brief interventions and referral treatments as like a process out in the medical field. I wanted to know where it came from, why it was developed, and what's the true purpose, and where it all originated. Well, it came out of, it was developed for tobacco and alcohol use disorders originally. In fact, the tobacco cessation success that, the profession had experienced that, hey, this could work for other addictions too. Now, the current model wasn't feasible until the 1980s. And the early model had the CAGE, which you guys probably know what the CAGE audit for alcohol problem drinking is. It's the Michigan Alcohol Screening Test. But the World Health Organization got involved because they caught wind of this. And they kind of had a global perspective, of course, as the World Health Organization should. And they said, hey, look, they came up with the alcohol use disorder identification test that's now used pretty much for a lot of the SBIRT model. And the continued success led to the growth, and SAMHSA started funding support in the US. And in fact, if you want to know more about the history and the audit and the Audit C screen, go to SAMHSA's website. So, what's the purpose and why was it, developed? Well, it's a public health approach that's developed for early intervention and treatment referral to find or to screen for at-risk individuals for substance use disorders, um, and for to refer folks who needed treatment to treatment. You know, it was a systematic, standardized process, if you will, with evidence-based tools. The analogy that came to my mind with this is it was kind of like catching fish and creating a larger fish net, okay, through the SBIRT process to catch more fish with a substance use disorder, let's say, in a stronger net. So not only to catch more fish, but a stronger net to keep the fish in or refer them to treatment, if you will. So that's a good analogy that I kind of thought up of, a larger net that can be applied and administered in multiple healthcare settings, including primary care settings, office and clinic-based settings, and other community settings. Something that was systematic, that could provide brief treatment for less severe cases, and then also provide specialized referral for more severe cases, right? So the main goal for SBIRT was to be able to administer this larger fish net, if you will, stronger fish net, to improve communities by reducing the prevalence of adverse consequences of substance misuse, including substance use disorders, through early intervention and, when needed, referral to treatment, okay? If that makes sense. It's meant to be, it's strategic, to be easy to administer by clinicians, very convenient, easy to administer in multiple settings, so we can catch what, more fish, right? Folks who perhaps had issues that need help or just needed education, you know, because I think there's a prevention aim behind all this too. So here's the obvious acronym. What I want to say about the acronym S is this has nothing to do with substance use, misuse, abuse, whatever. It's screening. This is kind of a template that you can use on substance addictions, including gambling, all addictions really. And I'm going to talk about the specialized tool. I'll term it as SBIRT here in near the end. Also, I want to make a comment of motivational interviewing. This isn't a formal motivational interviewing training, but you're going to hear snippets definitely of it, because I think motivational interviewing should be carried out from the S to the T, if you will, all the way from screening to brief intervention to the referral for treatment. I mean, look, you know, my bias is toward, I love motivational interviewing. I try to use it in my own life upon my own self. It doesn't always work with me. I'm stubborn, but we're going to talk a lot about that, especially during the brief intervention stages. Now, here is your first learning objective, the 4 aims of SBIRT. One is we want to identify folks who are at risk for alcohol problems. Second aim is we want to build awareness and educate folks on the U.S. guidelines and risk associated with alcohol use. This could be to people who score 0 on an audit C, those who don't, you know. This is just to build awareness on the public about what healthy drinking looks like. And also, this is kind of the prevention element of it, you know, the education, building awareness piece. Thirdly, we want to motivate at-risk clients to reduce unhealthy, risky alcohol use, meaning those who don't have true pathology or alcohol use disorder that's diagnosable, someone who perhaps can cut down their drinking. You know, perhaps we can talk about healthy drinking habits, and then we want to motivate those who do have a diagnosable form of alcohol use disorder or alcoholism, whatever you want to call it. We want to motivate them to seek help for alcohol use. The next 3 or 4 slides are just meant, I just want to show you where problem drinking still is, you know, in our world, in the US, just to give you some perspective. These are some older slides I kept in this training. Alcohol abuse and dependence, there's 17.6 million struck with this compared to diabetes, 18.2. It's almost as many within a million. Few Americans were actually treated or are actually treated for problem drinking, while 2.8 million on average receive treatment annually. 17.8 need treatment. That's why we're trying to make this fishnet bigger and stronger to capture those. I thought this was a very interesting slide. I kept this slide because look at the cost, the economic cost. When you combine those of asthma, diabetes, and high blood pressure, they don't match that of 185 billion, which are the economic costs of alcohol problems in our communities. Wow. So I guess you kind of get the gist of where this issue with problem gambling or excuse me, I want to say gambling, problem drinking and alcohol use disorder come in still our nation and our world today. This is who we're really kind of actually targeting through the SBIRT process. This is really everybody. But the top 25 to 26% are who are engaged in either risky drinking behaviors or who are actually suffering from alcohol use disorder. Remember those first two aims of SBIRT. We first want to identify those at risk, which are this 1% who are actually suffer from the addiction, 5% who are at a moderate risk, and the 20% at risk, and they might exceed daily limits, but that top 25, 26%. Now, the second aim, remember, was to build awareness, that prevention kind of piece of this. I think that it overlaps in any way prevention efforts of our field. The bottom portion, that 70% of folks occasionally are non-drinkers who seldom exceed daily limits of alcohol consumption, I still think through the SBIRT process, they can benefit from just the education that we can provide through the SBIRT process, which is part of it. Now, look, I grabbed this from the SBIRT 3 training that was scheduled back in March, and we hope to still be able to roll this training out, but it was over college, the young adult population on our college campuses, okay? And when I was researching and looking through the gaming and the gambling of this population in college, I could not turn my head to what I was finding about binge drinking still. I mean, I went to college in the mid 80s, right? Rush chairman, all that, you know, but wow, it seems like it hasn't, you know, there hasn't been a whole lot of movement as far as numbers go. The National Institute on Alcohol Abuse say that more than 1,800 students die annually due to alcohol-related causes. 600,000 are injured while drunk, and 100,000 become victims of alcohol-related sexual assault. So I thought this was relevant, so I stole this over from our SBIRT 3 training. So hopefully you, and I'm sure you guys already understand, but I wanted to provide a brief review on, yes, it's still here amongst all populations in our nation and globally, problems with alcohol and alcohol use disorder. So now let's talk about that connection that I was briefly, you know, that I led to during our intro between alcohol and gambling. You know, it's kind of like peas and carrots for all of you that have watched the movie Forrest Gump. You know what I'm talking about with peas and carrots. They kind of go together, right? Now, as with all, if not most mental health disorders, gambling disorder rarely occurs without other significant mental health and addiction issues, right? In fact, gambling disorder being comorbid with other disorders is usually the rule rather than the exception. Looking at the top box here, of course, there are higher levels of consequences that come with frequent alcohol use when gambling because of the obvious poor judgment, bad decision-making, loss of control, everything that comes in with being intoxicated. Grant Potenza report that adolescents that engage in moderate levels of drinking are more likely to gamble. And then Hodgkins and El Gluble report that it's best to address both conditions simultaneously, which leads to better outcomes when it's comorbid, when problem gambling is comorbid with alcohol use disorders. In fact, Dr. Alex Blazinski, who did the pathways model, he said the same thing, you know, to treat both, you know, comorbid conditions concurrently. Now, I'm not saying that's always the case, but they both suggest that. Now, the NESARC study, if you don't know, was the largest study ever conducted in the U.S. on comorbid conditions. I think it was in 2006 or 3. If you know the year of the original study, text or chat it to me. But the thing here is, alcohol use disorder was the largest, or was, I don't want to say the most popular, but it was the most common disorder that was connected to problem gambling and gambling disorder when that was studied. And this study suggests that the genetic predisposition for both alcohol use disorder and gambling disorder influence both conditions. And in fact, this particular study said that 64% of those who suffer from gambling disorder and alcohol use disorder was attributable to genes that influence both disorders, meaning that genetic predisposition looked quite a lot alike. And if we remember, you know, this disorder moved from the impulse control disorder from the DSM-4 to the DSM-5. Now they're under the substance use disorder family. because of one reason was they're the second to the last. They have common brain physiologies. Also, they share that genetic overlap I just, stated. I covered the NESARC study just now. And there was a study done, I think it was Hodgkins and Raysiat. They talked about alcohol being a gambling tonic when folks, suffer from both conditions, when it's comorbid and connected. It's kind of like, people, and I'm sure of those of you who serve the substance addiction world population. Um, it's kind of like those who are, comorbid with who suffer from cocaine addiction, let's say, or methamphetamine and alcohol use disorder. It becomes the addiction and the craving comes to that combined feeling they have from both versus just one or the other. It's the same thing with gambling. The gambling, the beer in hand literally happens. There, the focus becomes, and the compulsion and the preoccupation comes to the combination of the two. Hence the name gambling tonic. Alcohol becomes when folks are gambling, and they often occur simultaneously. Okay, so far, let's compartmentalize in our mind what we've looked at. We've looked at those higher rates. So why do we use SBIRT with gambling clients? Or why do we use GBIRT on those suffering from alcohol use disorder or problem gambling? Well, number one, because of what I said in that very 3 or 4 slides, we want to assess for alcohol on all clients because of the high prevalence rates still in our nation, still in our world today, even on our college campuses. We need to keep our eye out because of those numbers and what studies still show with alcohol. Gamblers have a high rate of alcohol use. I just talked about the peas and carrots thing, right? The connection. The NESARC study, that huge study showed that's the most common with problem gamblers is alcohol use disorder. And then finally, a third reason why we want to utilize this systematic process in all kinds of healthcare settings is we want to uncover maybe other comorbid conditions, smoking, chewing tobacco, nicotine, marijuana use, any addiction. There might be 3 or 4 comorbid conditions, and we want to take this opportunity to uncover any type of addictions, either substance, gambling, you name it. Okay, and we can do that with this SBIRT process template. But let's stick with alcohol. Let's get a little bit more granular with our audit process. I'm going to talk about the audit. Now, again, it was developed by the World Health Organization. The audit C is actually the audit. It's the first 3 questions of the audit, okay? And it's going to be considered our brief screen, which will lead to our full audit screen. The audit C, let me go back, says it's less than 2 minutes. It's less than a minute, really. And the audit can take less than 4 or 5 minutes. Of course, it's valid, reliable. Hey, you can fit in another screen here too. When I talk about the GBIRT, we're going to talk about the brief biosocial gambling screen, but you can screen from other things too. The important thing is, the thing about SBIRT is it's a framework that is supposed to be very simple to administer. You want to stick to those evidence-based tools throughout, and you can get through, and we can screen and get people to help who need it and also educate them. Now, here's our first little snippet, if you will, or I'll just make mention of motivational interviewing. How to raise this first question is so important. Of course, we want to empathize and gain consent, and we want to ask a question. I reached out to Dr. Lori Rugel. For those of you who don't know who Dr. Lori Rugel is, she's a subject matter expert on problem gambling and mindfulness, actually. But when I was resourcing, looking to add slides onto this thing, Dr. Rugel's name was all over everywhere. So I shot her an email, and she sent me some pointers, going into this. And one of them was, she termed that first question as the gateway question. And she suggested this initial question must be positioned effectively in order to set the stage for the entire SBIRT process, to be on a positive tone for best results. That might sound obvious, but remember, it's kind of like a leadoff hitter in baseball. Boy, you want to start off with a walk or getting somebody on base so that we're going to have a good inning that might produce runs. It's the same thing with this SBIRT process. That gateway question she positioned as needs to be effective. This is an example of one that's pretty wordy and pretty canned, but it's an example. It's a good example. And, it asks hey, look, I'd like to ask you several or a few questions about alcohol use. I ask all of my clients these questions because sometimes alcohol plays a role in the situations that leads folks to treatment. Sometimes it can be a problem. Do you mind if I ask you just a few questions? Is a good example. Here's the actual audit C, those first 3 questions. And it asks, how often do you have a drink containing alcohol? 1. 2, how many standard drinks containing alcohol do you have on a typical day? And 3, how often do you have 6 or more drinks in one occasion? The way we score this is if they answer A, it's 0 points. The B option is worth 1 point. C is worth 2 points. The D option is worth 3. And E is worth 4 points. So for instance, how often do you have a drink containing alcohol? If you say 4 or more times a week, that's 4 points, right? Question 1, if they answer no to how often do you have a drink containing alcohol, guess what? All right, that's a no. So you move on. You give them a positive affirmation. You give them a little bit of education if you feel is necessary or appropriate, and then that's it. In fact, if you've had a physical, okay, like myself, let's say last year, your doctor probably asked you a few questions about alcohol. Guess what? I guarantee you, I bet it's part of their SBIRT process, right? And if they ask you a couple questions and you don't drink, that was probably it, okay? So that's an example of the SBIRT process in play out in an outpatient setting or just at your doc's office. Now, also know that 40% of adults, don't drink alcohol at all. That's good to know, because a lot of people who perhaps are moderate or at high risk for drinking are in environments where they don't know what that reality really looks like, right? And we want to position that in a careful, sensitive way, but it's good to let them know that. The second question, I know if you work with the audit, you've got to confirm or clarify what a standard drink is, because with a lot of our clients, especially at the high risk, a single glass might have 7 standard drinks in it, right? So, we've got to check what constitutes a standard drink. If I have any housewife fans out there, this comes from the New York version of Housewives. And I believe this is Dorinda. This is what she constituted for their weekend at the winery. Not that I know about the Housewives. I might pick up on it when I walk by the TV as my wife is watching. Haha. But if Smithworth is watching this, that slide's for you. But what constitutes a standard drink, right? Here's a great, scale or guide. This deck will be on the UNC Behavioral Health website, Springboard website. So use this template if you want here, or anything on this. But this is a good one to have at your desk if you're new going into substance addiction work. That's a great quick guide. Now, when we do this in person, I kept this because we do this exercise with people. And those of you in the provider network who's been in summer school and heard our full version, we do this exercise. Look at number 1 and look at number 3. Let's take out that Jack Daniel's bottle, and let's just say there's 3 shots of whiskey. What's worth more standard drinks, number 1 or number 3, which is a 40 ounce of malt liquor? Well, it's the 40 ounce of malt liquor. It's worth 4.5 standard drinks. Here's a good not a template, but maybe a good guide to help you remember. 12 fluid ounces of regular beer, or light beer is considered regular beer, equals that of 8 to 9 fluid ounces of malt liquor stronger, which equals out to 5 fluid ounces of table wine, which equals out to 1 shot or 1.5 fluid ounces of 80 proof spirits or whiskey or other forms of alcohol. What you probably already know, if you work in the field of addictions, that most frequent drinkers, as I said earlier, and that includes a lot of women, report drinking larger than standard drinks. And a majority of drinkers underestimate, surprise, surprise, right? Their number of fluid ounces by about 30%. Okay, so if there's a positive screen, what does a positive screen equal? Okay, so it's 4 or more with men, 3 with women, and 3 with the older adult population. Remember how we score the 0 to 4, scale. If they score positive, does that mean we're going to call the ER services and get them to detox? Absolutely not. A positive screen means 2 things for you as the clinician or counselor. Number 1, you're going to administer the remaining 7 questions, okay? Number 2, you're going to determine their level of risk, okay? So if they scored 4 and they're a male, you know, then they're at low risk, okay? But we need to see if they at low risk or remain at low risk as we progress through the complete audit, okay? Or do they move to medium, or they move to high risk? The questions are scored the same, 0 to 4. During the past year, how often have you found that you were not able to stop drinking once you started? Never is 0 points. Less than monthly is 1. Monthly is 2. Weekly is 3. Daily or almost daily is worth 4 points. Question 5 asks, during the last year, have you failed to do what was normally expected of you because of drinking? 6 asks, during the past year, how often have you needed a drink in the morning to get yourself going after a heavy drinking session? 7, during the past year, how often have you had a feeling of guilt or remorse after drinking? 8, during the past year, have you been unable to remember what happened the night before that you'd been drinking? 9 and 10 are scored differently. 9 asks, have you or someone else been injured as a result of your drinking? If it's no, it's 0 points. If it's yes, but not in the past year, it's 2 points. And if it's yes, during the past year, it's 4 points. 10 is scored the same. Has a relative or a friend or a doctor or other healthcare worker been concerned about your drinking or suggested you cut down? This is how it's scored. 8 or more, I'm going to say has potential for harmful or hazardous drinking. Remember, you know, I'm moving through these slides very fast. If you want a copy of these slides, please go again to the UNC Behavioral Health website. So, but if they score 0 to 7, it's low, considered low. If it's 8 to 19, it's moderate. And if they score 20 to 40, there's possible dependence. So what do you do now? You just completed the S portion of SBIRT. Well, we go into the BI, which is brief intervention. One of our learning objectives that I covered today promised you that we would tell you what the formal definition of a brief intervention is. And it's short in length and duration, and it's aimed at helping a person reduce or stop a problematic behavior, and it happens right now after the screen, right? So when I started into this department, and remember, I'm a career changer. A lot of you have probably done this much longer than I. But when I got into this, you know, in my department, a lot of folks, I love the show Intervention, okay? You may or may not, you may throw tomatoes at me via Zoom. But I get it, you know, those are more acute cases. And a lot of times, if you've worked in this field, you know that when they're at that point, and especially the cases on that show, a lot of times those interventions are better for the family members than those that are really struck with the addiction, right? Once those boundaries are drawn, as directed by the interventionist, a lot of those folks get well. But I'm not saying bring a bat to a brief intervention. In fact, these brief interventions, again, as I said earlier, are intended or to be used. They're supposed to be shorter in this process, and we want to utilize those motivational interviewing techniques to meet folks where they're at, to perhaps so that they can make a healthy decision. So the brief intervention in the SBIRT process is designed to be short, non-confrontational, right? And it's supposed to motivate folks to do something about their problem, their issue, and it's effective with other addictions as well. As I said, I'm gonna do a GBIRT, go over that here in a few slides. Now, generally speaking, with the brief intervention, although it's supposed to be brief, you've got some ground to cover in the BI portion. You got to give them the audit score, comparing it to national averages when you're dealing with alcohol, because that's going to help build their awareness and self-awareness. It's going to provide education. You're going to give advice after asking permission. And, you know, you might even talk a little bit about action as you move into the referral for treatment stage. I added this slide because I think it's important. I'm all about frames. Remember that the responsibility for change is on the client. It's not your responsibility for them to change. It is your responsibility to do your best so that they can make an informed decision. But we all know when pathology is involved, you know, making a rational, informed decision can be a challenge to a client. So we're there to guide them, right? With feedback and advice, we want to give it in a non-judgmental way. We want to ask permission. Menu of options. One thing I've learned is one of the best options you can provide someone addicted to anything is the option to say, I don't want to do any of it. That is their option. The thing is, when you provide this option, I have found it loosens them up a little bit. Hey, I can always walk away. But you want to give context to that option or run the tape through, right? If you want to stay at this option, then nothing's going to change, right? Or studies have shown, and from my experiences, either if you're in recovery or if you treated a lot of people with alcohol use disorder, you know that this thing progresses. So let them know that they don't have to do anything, but it can get worse. Also, we want to utilize self-efficacy, like a template. We want to ask them what they've done well in the past. Maybe they can utilize some of those things in what they're faced with now. Here's another slide that I kept from the original SBIRT training a few years ago. I like it. When there's a low risk, we're looking at providing feedback, education, advice, and even follow up with our less severe cases. With moderate to high, as this thing progresses, as does your motivational interviewing skills, it progresses. It gets a little bit complicated, more judgmental. So we have to really dig into that frames. We need to really dig into our motivational interviewing to meet folks where they're at. When we talk about appropriate referrals, we want to have those relationships developed in our communities to know where we can send our folks. With gambling, that's what I'm going to cover because, hey, the awareness levels are lower still with problem gambling. The treatment resources are lower with problem gambling. So I'm going to provide you with a few, although it might be on the national level, it's something, but we'll get to that. Okay, so with the brief intervention on all clients, we're going to want to do these 4 things. Sorry, I'm having to shoot through these. But first off, we want to let them know what drinking patterns look like so they can compare. A lot of people, especially with drinking, especially with alcohol use disorder and problem drinking, we have found, they kind of, problem drinkers a lot of times use a template in their head. Well, what do I look like compared to what's, I almost used the term normal. What's the average? Okay, what does it look like with people who drink in a healthy fashion? Well, just know if they're high risk, they're in that top just 5%, right? And this is the folks who score the 20 to 40, where they exceed 2 or more of the recommended per day, per week, or per occasion limit. That kind of gives them some perspective of where they lie in the general population, okay? I'm going to talk about that exceeds 2 or more of the recommended here in a couple of slides, okay? Bear with me. The moderate score, 8 to 19, you're in 20% bracket of the US population, 35% is low risk, and 40%, remember, they don't drink at all. And that's important to let these folks know, especially those at all risk levels. Now, when we're providing, and that's what I'm saying here with this slide, when we're providing the normative feedback and what the rest of the nation, those who drink or don't drink look like, sometimes it's a little bit of a sensitive subject matter. I mean, if you're at the high level of most clients, they know that internally a lot of times because a lot of times they've been there for a certain amount of time. People have told them, doctors have told them, so they know. But it's still good to let them know where they lie in the population. For instance, even at moderate, you want them to know that, hey, maybe, no, not maybe, 3 out of the 4 drink at levels below yours, just so you know. So sometimes it's painful information for them to take in, but it could save their life, especially at high risk levels. So you guys probably know, maybe you don't if you're new into this field, the 2, 14, and 4, we can call it pattern guide, and the 1, 7, and 3. 2 means no more than 2 drinks per day. 14, no more than 14 per week. 4, no more than 4 weeks per occasion for males under 65. For men over 65 and females, it's 1, 7, 3. This is a good pattern to follow, healthy drinking patterns, right? That we need to inform all levels of what it looks like, okay? Again, this is a great guide when we provide the education and the advice. I'm not going to go over this, but we want to provide that. That's our left bubble, our right bubble. Let them know, even if they're at low risk, if they move to moderate or high risk, man, the things that are connected to it, injury, accidents, health problems, mental health problems, right? Now, when we provide advice, again, we want to ask permission. It can be very sensitive, especially with moderate to high drinking. I know from my experiences, if you have a client that's either in the pre-contemplation stage or just plain defiant, everything depends on how you position the advice, just like Dr. Rugel had said earlier with the gateway question. Sometimes the smartest goal I have learned personally is just to roll with the resistance, right? So they know where they can come back to in a supportive, empathetic environment when they are at the stage of change to get help, either if it's preparation or action. Does that make sense? So the smartest goal is to know when they're ready for help, where they can go, and that would be you. Now, when we look at moderate to high risk, we really want to, again, hone in or dig in with our motivational interviewing strategy. We want to be ready to discuss, navigate, and provide options, those menu of options. We want to be careful, realistic, and remember one of those options can be no change. When we're exploring readiness, what we're talking about is find their current stage of change and meet them where they're at. And when we're managing pushback, remember where confrontation and argumentation lands you with anyone addicted to anything. Roll with the resistance, right? And remember, it's not your responsibility for them to make that change. We just have to guide them there. Being a tour guide's where it's at. This is a great guide leading to how are we going to, if you were to decide to change, what might your options be? These are exploring goals, right? This is a very challenging time, especially after we kind of find the goals that we want to do. This is the discussion on how we're going to reach them, right? Both discussions at this point of the brief intervention moving to the referral for treatment are critical, okay? You got to stay away from cookie cutter approaches, even if they're at the same stage of change. Use your clinical experience, expertise, motivational interviewing techniques, all you need, because remember this is why I signed up to do this and change careers. Is a lot of times this is a life or death situation for folks, especially with alcohol use disorder. So to be there at that time when they make that decision to change their life is a wonderful thing. It's very difficult for them. Remember that. So we've got to guide them there. This can be, the big book of AA says it's a turning point, right? So we're there and we can help give them, through our motivational interviewing techniques, the way or the path to a successful recovery. So how do we do that? Here's a couple of tools that you can utilize at this point to find out where they're at, which is scaling. Hey, look, I use scaling in crisis work. I use scaling in addiction work. From 0 to 10, how important is this to you? From 0 to 10, how confident are you that you can do this, right? This allows you to kind of navigate where they're at, right? Where they're at on their action stage. We're going to find out if they're contemplative, if they're ambivalent when we scale them here. We're going to find out if they're, let's roll, if they're in the action stage. So scaling on, we're all for. Now with a high risk, it can always be tough. Remember, with evaluating barriers, you always want to run the tape through, if you will. You want a system with action plans, use your empathy, do all the things that you need to do, right, with that. And remember, when they know one of their options is, I don't have to do anything, that kind of loosens things up with someone who's addicted to anything. I don't know if that is your experience with that, but it definitely is with mine. Okay, so now let's look at the GBIRT, which is kind of the SBIRT for problem gambling clients, right? Now, in our SureBet 1 and 2 series, 1 through 6, we go through these screening tools. I added 7 and 8, which from this particular training that I resourced for this webinar, they use, and I agree with, the brief biosocial gambling screen and the PGSI, the Problem Gambling Severity Index. Remember, this is a template. The GBIRT is a template just like the SBIRT. It's the same systematic process approach that can be applied in the same several environments settings as SBIRT. So the job again, or the purpose, is to create a bigger fishnet and that you can easily administer in any part of the sea, right? And it's supposed to be stronger with evidence-based tools. We utilize evidence-based or gambling-specific tools that addresses gambling. So when would I use the GBIRT versus like what we just went over the SBIRT? A lot of this is obvious, but when if they come into your office and they just talk about gambling versus, any mention of a substance. They might mention substances, but they talk more about being in the casino for 2 or 3 days versus their problems with alcohol or opiates, let's say. So when there's signs and they lead with their gambling issues versus a substance, that's a good indicator to use SBIRT. When it might be when you suspect it might be the primary condition in just the example I just gave you. Again, when they lead with their problem, gambling issues, versus any other addiction or even other behavioral health issue. When it's a standalone disorder, it doesn't happen often, as we said earlier, but it can and does happen. So if it's the exception, this is a good time to do it. And then also, like with the SBIRT, it's a great opportunity to uncover other co-occurring conditions, okay? So what screens are we going to, well, the one we're going to talk about today is the brief biosocial gambling screen. 3 questions. During the past 12 months, have you become restless, irritable, or anxious when trying to stop or cut down gambling? During the past 12 months, have you tried to keep your family or friends from knowing how much you gambled? During the past 12 months, did you or have you had such financial trouble as a result of your gambling that you had to get help with living experiences from family, friends, or welfare? This is like the audit C with the alcohol. So if they score 0, you do this. You give them a positive affirmation, maybe some education. I think with gambling, it's more important to give some education because there's not a lot of education out there on problem gambling, right? Okay, so that's kind of a little bit of a difference. But so let's say they answer yes to any of these or more than one of these. That means we're going to do what? Just like moving from the audit C to the full audit, we move from the brief biosocial gambling screen to the PGSI. Why? Because we want to determine their level of risk. Here's the full PGSI. There's 9 questions. I'm running short of time, so I'm not going to go through these questions. I will say they're from the South Oaks gambling screen, the DSM-4. Some of these questions, I will say, once I look through this, they blend in with these 3, okay? But that's okay. This is what you want to look at as far as the score. 2 or less is low risk, 3 to 7 is moderate, and 8 or higher is high risk, right? So what does that mean? What does that lead us to? Well, we're done with the S. We're done with the screen. So we need to move into the what? The brief intervention. When we look into the brief intervention, according to this training that I resourced, there's 4 steps to this. Now, with the alcohol brief intervention, it was a little different. You compared it to national averages. You said, what someone who drinks in healthy patterns looks like. You gave them some, information. You can do that here too. I mean, as far as national averages, what is it, 2.5% in North America, the folks who suffer from gambling disorder, you can tell them it's not as prevalent. You can give them some psychoed here in the brief brief intervention process. But you definitely want to hit on 4 of these things through your motivational interviewing lens. You want to raise the subject. You want to build rapport. You want to use empathy. You want to provide them feedback. When you provide them feedback, you want to do what you want to ask them permission. You want to utilize reflective listening. And when we talk about enhancing motivation, what they're saying here is you got to assess the readiness for change. That goes back to the screening, right? So you want to kind of find out where they're at so you can meet them where they're at, depending on if they're, at contemplation with some ambivalence, or they're ready to go and they're already in action. We need to be able to come with our skill set at that step of action or level of action. And when we talk about negotiating and advising, we're talking about working with them to make sure that they're practicing their self-efficacy, what's worked in the past, have them harness their own strengths from past accomplishments to what they're looking at, summarize with them, and lead them into the RT portion, which is the referring for treatment. Now, I'm going to stay along these same planes. I'm going to refer to some things with the American Society of Addiction Medicine that includes these 4 levels of care, okay? And it's outpatient, intensive outpatient, or partial hospitalization, IOP, or residential service level of care, or the medically managed intensive patient, right? But what I would like to do at looking at these 6 dimensions, which is one of our learning objectives, as you probably know, or maybe you don't know, these 6 dimensions we have to run through with our client in order to see where they're going to set here. Okay, and when we through these 6 dimensions, right, we want to use what we've learned from the screen in the brief intervention, excuse me, to land them in one of these 4 levels of care that are set forth by the American Society of Addiction Medicine. Okay, but how does it look with gamblers? So what I did was I took this from a Dr. David Me Lee. I've referenced him at the back of this training. It's great stuff as far as gambling and what it looks like on one of his presentations with a gambler with each 6 of these. Let's start off with the acute intoxication withdrawal potential. You know, with gamblers, it's usually in the form of extreme irritability, reported tunnel vision, restlessness, and shaking. During this COVID time, you may see a lot of this, and it may lead to domestic violence. So we want to be checking, and we might, through the SBIRT process, see their irritability and restlessness, you know, how they're feeling with that or where they're at with it. Now, we got to check comorbid conditions, really with substance addictions with this first dimension. Why? Because you probably already know. Alcohol withdrawal is the most deadliest with delirium tremors, alcohol poisoning, all these things. So we have to check on those levels of alcohol use. Opiates is another deadly withdrawal. So we need to be checking those traits of physical withdrawal, because you know we may need to be getting them to a hospital to their detox. So with gamblers, be looking for those comorbid conditions, of course. And then when we look at biomedical conditions, and we're assessing it for any accompanying physical condition that results from prolonged periods of gambling, we're looking at things like, you know, we want to ask them about high blood pressure, heart problems, urinary tract infections. Why? Because a lot of times gamblers in most acute cases stand in front of machines for 3 days on end with either diapers or holding it in or just going, you know. So urinary tract infections can result from some of those things. Sleeplessness, fatigue, ulcers. Again, we need to check our comorbid substance addictions here with alcohol, the liver problems that are connected to all substance uses, especially alcohol. Now, when we go to dimension 3, we're looking at comorbid mood disorders. This addiction, amongst all other addictions, gambling addiction, has the highest suicide potential, right? Or a lot of times. So we need to assess for major depressive disorder and even dysthymia. Even with additional addictions, if we're just doing alcohol use disorder, we want to ask them about even family history with depression. Now, when we look at dimension 4, we're assessing for readiness of change. I've talked about that throughout. Is the motivation just from external or sources, or it's in consequences, or is it internal, or both? Criteria 5, we look at relapse, continued use, or problem potential. We want to assess for the clients, you know, their awareness levels with their triggers and where they're currently at to cope with them, and what is the client's treatment history. Is this their 8th time, or is this their first time at recovery? Finally, with recovery environment with a gambler, I think we need to look at their level of debt. Debt is a big trigger, because you tie debt in with being close to a casino. Like from my house, I can see a casino here in Boston, in Charlestown, Encore. We got to check for things like that. We got to check how close. There in North Carolina, I know scratch offs are a big deal. How close are they to a convenience store? If it's alcohol use disorder, how close are they to their bar? We need to know this. What about their family? What about their living setting? Do they live with gamblers? Do they live with folks who play the lottery? Do they live with, what do their social circles look like? All these things come into play, and even with substance addictions, right? All the things that we want to consider through the ASAM. So remember the gambling pieces of this. Remember all the things that go with the substance use disorders with recovery environment. Here's a good guide that we take actually from what our counselors see on the Problem Gambling Helpline on these 6 dimensions. This is more related, a lot of it's to substance addictions, right? But I wanted to show you that. You can have this on this slide and use this in your own practice or agency. Now, the referral treatment options. Number one, we're a great one. And I'm not just self-advertising, but we're really a good, send folks who you feel fall under the outpatient options to us. The Problem Gambling Helpline of North Carolina, they can get up to 12 services through our provider network. All our providers out there, you know this, right? If they're not ready yet for face-to-face, they can start with our 5-session model over the phone, either because they're geographically, if there's a challenge there, or if they're just not ready to see someone face-to-face. Lastly, Mark Lefkowitz, if you don't know Mark, he talks quite a bit at the NCBG conference. If you've been there, you've probably heard him talk. I call him the grandfather of gambling training. He provided these for us. The 3 top programs are at Algamus in Prescott, Arizona. It's the only private pay inpatient gambling treatment, gambling only treatment in the nation, private pay inpatient. Then you have CORE in Shreveport, Louisiana. In Minnesota, Minneapolis, you have Project. Those both are state funded. A couple of hybrid ones on the West Coast. Compass Recovery, again, in Prescott is a hybrid. Hybrid means they treat substance addiction as well, but there's a gambling focus. Bathsheba in LA is a great one. It's state funded. I don't think you should send someone to IOP treatment from North Carolina to San Diego unless it's really a weather thing is going to really have anything to do with their treatment outcome. But UPAC in San Diego is another one I just thought I'd mention. But these are top national programs. I always get this. Hey, where can we don't know where to send inpatient, those who qualify for inpatient. Remember with gamblers, a lot of folks who have to go, who are sectioned, that we call in Massachusetts, sectioned to go in, or they need to stay in the emergency room. With gambling, it's mostly due with suicide ideation and past attempts connected to their levels of debt or connected to the shame that's connected to, this horrible addiction, right? Sorry, guys, that leaves me with 2 minutes for questions. We can run over a little bit. I'll answer what I can here. That was a lot of information. I didn't want to cut any of it out. So I wanted to get in everything I could. So let's look. I had a couple of chats here. Let's take a look at the chats first. Okay. All right. Barbara Kaplan. SBIRT and nods in the public domain so that they are free of cost-wise and can readily be used without violating copyright. I don't know, Barbara, what you're asking there. I believe you can use these. You can use what I've given you off of the this template here, but by all means, a lot of these screens, screens are, you're good to use. In fact, we have a 5-day UCLA handbook that you can get right off that utilizes a lot of these screens right off of the internet. So maybe you're saying, okay, gotcha. Thank you. Thank you, Yalen. Let me look at the couple of questions here, and we're right at the hour. I want to thank everybody for coming on. And before we get at the hour here, remember June 15th, Responsible Gambling 101 with Julie Hines. She's great. She's going to be talking on prevention. Okay. Yes, the PowerPoint's available on the Behavioral Health Springboard website at UNC. Can you use SBIRT for problem gaming as well? Good question. Does North Carolina Problem Gambling Hotline also provide counseling for problem gaming? Very good question. Gaming is actually considered from the World Health Organization as a formal disorder. The DSM-5 doesn't see it that way just yet. It's in the batter's circle. As far as gaming, all of our counselors are, master's level counselors. I will say this, they can help because of the overlap. If any of you guys have sat in on our talks on gaming and gambling in the DSM-5 and what it looks like, I think 7 out of the 9 perfectly match up, okay? I'm sure our counselors on our line will be able to do some brief counseling, perhaps maybe even be able to refer as far as the North Carolina Problem Gambling Helpline goes with gaming. I can't say that any of them are really either certified or specialized at that point, but we're all open to making quality referrals. The SBIRT or the SBIRT can be used on any form of addiction, I believe. So yes, so those questions as far as gaming, you know, we would look at some screens made specifically for gaming, but a lot of the screens you could apply towards gaming disorder. But that's a good question. And when we hang up, I'm going to look at perhaps some specific, maybe evidence-based screens. Anonymous attendee, if you've got an email address, please let me know, because I honestly don't know what screens are out there that pertain to gaming. You know, I believe that it is a disorder, and it's an addiction that really steals the time out of young folks and even middle age and older adult populations with gaming. So I'm sure with the gaming issue, we can lead a client to a quality referral. And even if it gets to our referral network, they would still do the same. Those who perhaps aren't, I would say, competent in providing that type of counseling, they could refer on to someone who is. The SBIRT can be applied, yes, to I believe, gaming disorder, but we would have to perhaps tweak some things and provide during the brief intervention that this can be considered. In fact, it is recognized by the World Health Organization as a disorder. I hope that's helpful. Good question. Okay, any other questions? Okay, guys, again, thank you. We're just 3 past the hour. We will see everybody. Somebody. Okay, you bet, Amy. Good question. About the gaming in the screens. I'm going to look that up myself, and I might go to our subject matter expert on young adults, Allison Drain, if you're on. Let's see here, chat. Got a couple other questions. Thank you, and thank you guys. Thank you for the great questions. Thank you for listening in today. Again, June 15th, Responsible Gaming 101. Everybody have a great day, and thank you.